Hey everyone, this is the Manips Sips podcast. I'm featuring Dr. Jeremy Boyd, my partner in crime over there, Dr. Brandon Cruz, and a very, very special episode today featuring my biggest mentor, Dr. Tom Michaels, who I worked under for probably close to 3-ish, 4-ish years. I've been looking forward to this episode for a very, very long time. The essential, probably original Manips and Sips really started while I was working under Tom. So Tom, welcome on board, and yeah, thanks for
Good to be
coming
here.
on. So
Yeah, I never thought about this. The whole thing starting with us doing beers after work while we're just BSing and finishing up paperwork.
yeah, not until I started typing out those questions, I was like, oh, I was just like thinking of the most like fondest memories of working with you. I was like, oh shit, you know what? He used to bring beers on Fridays. He'd bring it, he'd give it to the staff, and staff would kind of like have one and leave. Me and you would finish off the rest. And I was like, that's where we had some of our best
Yeah,
mentoring conversations, both in life and clinically.
yeah, very
Uh,
true.
so I appreciate all those from both a clinical and life standpoint. But yeah, I guess we'll talk more about that. But I guess starting off with tradition is talking about our drinks and that sort of stuff. You also mentored me into that, to grow up from land sharks and Coronas to some more serious drinks. So thank you for that.
Yeah, well, that stuff's evolved like crazy in the last few years. Great.
Uh, but yeah, Tom, what are you drinking?
Uh, you know, Jeremy called me the seasoned therapist of this little podcast. So I have like a 40th anniversary Sierra Nevada.
Well,
It's not even my age, but
it's about half
awesome.
as long as you've been practicing.
Yeah, true.
Huh?
My football team no longer has a football name, a name, although I
Oh,
learned them a little bit with the logo. Can't say who they are, but
I have a feeling you're
dishwashing.
not fond of that name change there, or lack of.
I just want a team name. Not even, I feel like you remember a few years ago Prince became a logo.
Yeah,
I feel that's how what the team is like.
it's a logo. It's starting to trend.
I kind of like the Washington football team logo, I like the establishment and that sort of stuff, but it is a little whack at times. But Alex Smith is back,
Yeah.
so that's a great testament to physical therapy and
Oh my
medicine and
God.
that
Yeah.
sort. How many surgeries do you
ESPN's
have? 17?
He almost
what's
lost
that?
his leg. Yeah.
Huh?
The ESPN did a great like 30 for 30 on it, showing like his whole journey. It was really. I didn't think it was after I saw that. I thought there was no chance he'd ever actually get on the football field. Watching kind of where he was,
Hmm.
just probably like a year ago. It's actually amazing that he's playing again.
Yeah,
He's gonna
amazing. He's
go for drop foot.
Yeah, it's nuts. And his graft, I mean, I saw pieces of it. I mean, it was pretty gruesome looking where they
Yeah.
just like repaired everything. And sad yet amazing thing is he is the best quarterback on your team. Uh, so I mean, Haskins and everything like that. I mean, he's actually playing really well.
Yeah.
Just needs some
At
touchdowns.
least I can finally be close to you now that your Patriots have lost Tom Brady.
Yeah. We're not starting off the best, but it's how you finish, right? So, but yeah, Brandon, what are you drinking?
Yeah. So in honor, this kind of just happened to work out this way. It wasn't planned. In honor of Tom practicing 20 years, I have Johnnie Walker 18, but it was bought for me about 2 years ago by Jeremy. So it's now 20 years. So that's what I am sipping on today. And it happened to be worked out that Tom has been practicing 20 years and will be
Look at
kind of
that.
a bit of a theme on the show today. So what do you
Yeah.
got? And then we'll get
So I have brought out something special. It had more wax on here, but I didn't want to look like an ass on live here. So this is from our local brewery in Glassboro, New Jersey, of Axe and Arrow. I've had a couple of their beers, but thought it was fitting today. This is a cherry sour beer, aged just like Tom a little bit in bourbon barrels, whiskey barrels. I'm pretty sure they use Maker's Mark. So I've been holding on to this for this episode. I'm excited for it. I will let you know how it is. But yeah, while I fiddle with this there, Tom, why don't you tell us a little bit about yourself, everything, your career, and can talk about some of those other things that we brought up pre-show.
It's I kind of got into the profession like I said, like 20 years ago. And back then it was just a master's degree. So I got my master's starting out. And back then, if you look at any research article we kind of go by, none of that was there. So everything was just done around what we were told to do. Sadly, ultrasound was popular and STEM was popular, and all that stuff is what we just did because we were told to. It's nice just in time things kind of started to evolve, and then when the doctorate started coming out. So for me, the whole doctorate has a whole different perspective because that was a new thing. So I had my master's, and then all these newer therapists started graduating with a doctorate. So residencies, all board certification, that wasn't really the option. So for me, it was like, okay, now these new therapists are coming out with doctorates, which I just have a master's. So they're touting that they're more highly trained, even though the education was very comparable. So then I decided to go back and get my doctorate. So in my mind, it was like just level the playing field. I have mine and experience; they have theirs, so it's kind of like checkmate. Again, like the board certification wasn't really something back then. So that's been like the coolest thing. Like since that stuff has happened, like it's just been like crack for this profession that's becoming so much more highly skilled. We got all this evidence and all this other stuff to just drive what we do. It's cool. I mean, and back to kind of what we're talking for me. I bounced around in like corporate stuff for a while. I took a job as a manager 2 years out, which that was back then when I started. That was like, that was like the progression. You got your job and you went into management. All this higher level advanced training stuff wasn't really out there. So that was kind of like professionally, that was the step you took, was to become a manager. I look back, doing that at 2 years out was stupid because I needed to really focus on being a therapist. But in the same token, I learned how to multitask, and you learn about the business stuff very early on, which now the way the profession has evolved, that is such a huge thing. So luckily, I've been around that for a long time. And then it was like 2013. I was kind of looking for a change, and the company I work for now was just growing, and they were more focusing on education, and the board certification was becoming a thing. So both life-wise was closer to home, and professional-wise, I'm like, okay, I want to take a step to something a little more advancing myself in the profession again. So that's when I left my old job, got out of the corporate setting, got into more PT-owned setting. Part of that was to go and get my OCS. Luckily for me, I had already been practicing for a while, so I met the criteria. I didn't have to go for residency or sit for it early. But the prep for that was just amazing, because where I got my DPT evidence and research was not a big focus at that school. So my prep work to get my OCS is what I really threw me into learning about evidence-based practice and all that stuff. It was like game-changing for me as a clinician. Like, I think I was doing decent as a PT up to that point, but once I kind of got into learning all the evidence and learning to balance everything, and it was everything changed.
So, Tom, I have a couple questions actually on some points that you brought up, and please tell me your mindset then, and maybe even now if it's changed. Something I get questioned a lot from more so new grads, not so much students, but new grads. And if they're in a setting where somebody still has their master's, they're hesitant to refer to themselves to a patient, or in that setting, I'm Dr. Cruz, I'll be your therapist today, you can call me Brandon, or whatever that introduction is. They feel like they can't call themselves a doctor because their colleague, who has more experience and probably knows more on how to treat and manage and things like that, doesn't have that. So they feel like they can cross that line or things like that. Do you feel we should be addressing our patients with that title? And how did you feel? Like you said, you went back to school to kind of one up or checkmate. All right, all these kids are coming out hot shots, they don't know shit, but I know I need to still kind of move with the advancement of the profession. And you went back and got your DPT. Can you kind of elaborate on those two things there?
Well, I don't. So I don't like to call myself doctor. It's part of that is too. We're kind of the nature of the beast of our profession is working with people, and we need to, as much of it as it's the clinical experience and excellence and knowledge. It's that personal side. So the referring to me as a doctor, for me, kind of, you want them to look at you as a person also. So I kind of steer away from that for that reason. There are times where I'm going to kind of, if I get a person that's not what is challenging me with my, what I'm telling them, I will refer to that. And I'll use that to my advantage to say, look, I do have the knowledge. I can talk on this level. But that's where, we're in a tough spot as a profession because we're so built around, working with people, gaining trust. But the doctoring title makes you the alpha. It puts you as a superior, but it puts you on this, it's more of an impersonal relationship, in my opinion. I would love to be able to marry those two things.
Yeah.
But at this point, I don't know how we do that. And maybe as the profession goes on and all the older therapists that didn't get their doctorate start fading out, maybe when the whole profession is just that, and that's a thing of the past, maybe that's the time that we start to do it.
Yeah.
But it's tough. And then for that new therapist coming out with their doctorate, having a manager that just has a master's or something like that, it's their boss. So it's tough you feel disrespectful, but I don't even really know how we handle that.
Yeah. It's a can of worms, and not to put you on the spot there, but I want to get somebody, different perspective. We also right before the show, we had a comment that was said where it was just like, patients still think that we're a weak insert. Like, does that title kind of show, listen, we're more than personal trainers, we're more than a weak insert, and just hearing your perspective on that, it was great. My follow-up question was, with your transition to going more OCS and evidence-based, I guess how did that really, I guess, make that change for you clinically, where or maybe combined with more direct access and things like that? Do you feel that helped? And maybe talk a little bit more about balancing out that pyramid of evidence-based practice versus solely relying more on just your clinical experience, but now you're incorporating some patient values and beliefs and some of the newer research that was out there.
Well, it's great because you have both. I had 12 so years without having any evidence to just truly go by my own personal experience and my clinical decision making based on what I found to work. Back then I always kind of just looked at every patient as a little mini case study. But I would try this, and if it worked, okay, great, keep that in the back of my mind. Kind of just building up my knowledge that way. So it kind of was my own little mini evidence. Yeah. Obviously it didn't count, but I didn't have any biases of evidence either. So that's what evidence is. It's great because it gives us reasons to make our statements, things to back up our statements, which we didn't have then. So that's what's, you can kind of balance the two. That's what I'm lucky, because I have all these years of doing things without being biased by what the evidence told me I should do. Evidence is great, but it's also it's all based on very, very strictly controlled studies. So you don't have those variables that you get in the clinic that alter things. Somebody's, a person's, what's going on in their house, what's going on like more in their past, their psychosocial stuff. It's so regulated, controlled. It's got to be balancing the two things, and that's where I saw probably like 5 or 6 years ago, when a lot of the schools were just all the clinical prediction rules, all that stuff was that became the end all and be all, and they kind of forced you to not look at anything else. It was the evidence says it's there, you have to do it. If it's not there, you can't do it.
Correct.
It's not in the last couple of years. I'm seeing that changing already. So thank God.
Going back,
We're almost a little too far away from it. It's we have to learn to marry the two things.
It's true, and
I'm lucky because I have the experience to use to make my own opinions, whereas newer therapists don't have all that unbiased time to formulate their own, opinions on what to do with things.
Agreed. Jay, what were
I
you
think
gonna say?
it's like ties into like the fact like sometimes we have like people asking us, oh, when do I start residency? And some people want to come right off the gates. They graduate their DPT and they want to hop right into it. And then they aren't able to have those experiences and they purely rely on the evidence. And I think, I drank the Kool-Aid with a lot of things with my residency and under your mentorship of like, there's a period where I was trying to pain science everyone to death, and you told me I was going to burn out. Just watching me one after another having these way too lengthy conversations. There's a period where I completely threw out any sort of potential that could be SIJ with a lot of people, and I was missing the boat on a lot of these sort of things, and just purely applying the evidence of eccentric loading to like tendinopathies and not looking at the why that tendon was getting irritated in the first place. And a lot of these sort of things, if I wasn't properly guided, in your case with the experience that I did not have, I would have just purely been applying evidence and probably would have never gotten all those clients as where they get better. So I think that's, a good kind of discussion with those sort of things is maybe we do need to wait a little bit before we start going like gung-ho with more advanced training and those sort of things. So I think you did an awesome job making that segue, where a lot of people in your shoes would just be like, oh, I'm good enough. I have experience. I don't need to do anything more than that. So I think you did the perfect blend of, experience plus advancing yourself. So kudos to you and thanks for all that.
Quick question: How did direct access change things? Like, what was now it's more mainstream. Was there a lot of pushback back then? Did you feel?
Oh yeah, it was.
Yeah, what was that like?
It was huge. I would, with doctors I go and do hours with and rounds with, and they thought it was stupid. They're like, how can you go and see somebody without seeing me first? They even now the doctors still don't understand direct access. I mean, that's a lot of us as a profession. We need to be promoting ourselves.
Yeah.
With that, but it's tough too because even now you get to some of the corporate therapy companies, they won't do direct access.
Yeah,
a lot of them don't.
And so and then back to like with the students going in, how soon do you go into residency? It's kind of married into where you choose to start working. So it's like, if we're very much creatures of habit. So if you choose your first job, you end up picking something, and it may not be the evidence-based stuff, but you settle into the routine of it. You will adapt and get used to doing it, and then you kind of at some point you lose kind of that perspective of what you wanted to get to because life is going on. And then, at the age where we all get into the profession, life events start happening. With people get married, kids, house, all that stuff. And then the further you get out, the more those variables will impact your ability to make a change to better your profession with, residency or whatnot.
Yeah.
So like for me, I kind of think that stuff kind of outweighs allowing yourself to sit and work for a couple of years before going into like a residency, because you're in the school mindset. Life stuff hasn't started impacting things that, some people can manage to do both. I wouldn't have been able to.
Yeah, I agree. I mean, I went right into it because I had that mindset of I'm younger now. I don't have other things in my way, and I'm in that mindset of school. And then I've seen people, with, a husband or a wife and 2 kids, and they're up till 3 a.m. trying to, read some articles and put a post. I was like, I don't know how you do it. I mean, which I even commend them even more for even doing that because, it's hard. And I think that's the hard thing about our profession and why it's so hard to progress it is because once you start working a couple of years, you get used to that lifestyle or life events and things like that. And then you don't have your career goes on the backboard. And now you're just trying to make, your paychecks to support your family, and you don't have that extra time because you want to put that extra time towards your family. But then you never reach true clinical mastery.
And that's where, like, in academics, your clinical experiences, there has to at some point be a change in way, the ClinEd model is. Because it's absolutely ridiculous that the same CPI I filled out 20 years ago on a piece of paper is still what students are graded on for proficiency.
Mhm.
It's ridiculous.
Yeah.
It's horrible. Like, and the schools have no knowledge or involvement of what's going on in the clinics that they're sending these students to. So there's that, like we're talking about that, you're going from there's the academic stuff, then there's the clinical stuff, and then that could be the residency. That might be the bridge that, there's your time to be in the clinic and just kind of gain your experience. But are the students really getting the experiences they need on clinic to kind of set themselves up?
Mm-hmm.
Luckily, like, you guys and me, I take pride in giving and teaching my students and making sure they get the best experience. Mainly because I don't want crap therapists out there. I want to guide them in like the way to want to succeed as an excellent clinician, not to fall into this trap of just productivity. I think that might be the window that marries everything. That gives you that clinical experience and time to prepare you for residency. But if your clinical experiences are crap,
yeah, there's a stat out, and Jeremy, I've talked about it. I think 80% of therapists are like the rest of their career is determined on what they do in their first year or two out.
Mm-hmm.
So if you go work at a corporate place or a mill or a place that doesn't, like you said, have pride in what they're really doing, it's probably what you're going to be the rest of your career. And with that reflection, you had said something like when you were studying for the OCS exam, you thought you were doing good up until that point, and then you were going through that study process and your eyes were kind of open to some certain things. What do you say to those therapists now? And I see it now in people who've only been out a couple of years, and they're like, oh, I want to do more, but I'm busy, I can't. And then you talk about that. Well, how are your outcomes? Oh, my outcomes are fine. Like in their head, they always think our outcomes are fine because of course, people get better just by time. But unless you have somebody there or something that's causing some reflection, you're probably not doing as good as you think you are.
No, that's 100% right.
Mm-hmm.
So
I had a professor who, after I got my SCS, I was teaching him, and he's just like, if I were you, I wouldn't do any more after this. He's talking from a business standpoint and everything like that. It's like, why? He's like, it's not going to gain you any more money or anything like that. And I was just kind of took back by it. And I'm like, I'm not doing it for the money. I don't expect people to come up like, oh, you have your OCS and SCS, I'm coming to you. I mean, most of our profession don't even know what that is at this point. I still have people who have asked me, what do these mean? Actually, from schools. They're like, what's this cert mean? I'm like, I mean, you should at least know the main ones at this point. But, it's just to kind of keep pushing myself to learn more. Or as Brandon said, people think their outcomes are fine. Your outcomes are never fine enough. They can always get better. I talk about my old, case study that I presented at CSM where I got my balls busted for seeing the patient in 3 sessions. And I was mad at the person for writing, oh, you should have saw in 1 to 2. And now I do a case study a couple of years later and I saw him in 5. And now I'm getting mad at myself that I didn't see that person in 2 to 3 sessions. And that's it. Outcomes can always get better. Our experience that we can give to clients can always be better. And it takes, constant pushing yourself. And, Tom, you did it when, we're talking about people are like, oh, I got family, I got all these sort of things. I meant when you were going through your OCS, you had your daughter, right?
Yeah.
And other life things that I know about that we can, that'd be maybe another podcast episode or some other things. You're managing a clinic. So if there's a testament to anybody who can do it all,
I carried study stuff I remember sitting in a doctor's office waiting to get like my physical, and I'm like I'm pulling out like my little orthopedic book, trying to like just cram every little thing I could every free moment. It was great.
So I mean, little moments like that, you can take to keep pushing ourselves. We just, people think it's like, oh, I don't have hours to study. I mean, a little bit here and there does add up over time for sure.
Oh, absolutely.
But I guess we're talking on the point of like education continuing and that sort of stuff. I'm sure you've had a ton of people that you've mentored over the years, myself included, from both, just working under you as like, to prep to become a director. And then also while I was studying for my OCS. First, I guess just to kind of break it up, what was your favorite memory while I was your mentee, I guess?
Oh, that's easy.
Oh boy,
Sure,
I think
you
I
remember Dan, the first time you
yeah, I know it. Fuck it. I'm gonna take a big sip for this one.
You might want to just finish that whole thing.
Shit.
Oh, that was the best. You were struggling with that for so long, and then the timing was perfect. There was a patient Jeremy had really good rapport with, so the patient was very open to him practicing and trying to perfect the technique. And it was just, he's this big guy, huge beard.
Huge.
Yeah, it's such a
tree
nice
trunks
guy.
for him.
And I remember Jeremy just trying over, just couldn't get the cavitation that he wanted. Because, as much as we don't need it, it's still that validation that you got what you want. Yeah. But I'll never forget, like, sitting in the clinic. It was a tiny clinic, so it was maybe like 4 or 5 feet away with where I'm at. And, like, finally gets him set up, gets in the pistol, and gets the cavitation he wants, and he stays there.
I don't think I even had the cavitation at that point.
No?
I had the setup right. You were teaching me the setup. We're doing the supine pistol technique, and I just could never get the setup right, and I finally got it right. But I think he was like laughing so much, I was waiting for him to finish laughing to do the thrust.
It was just like this huge awkward pause, and then the guy's like, dude, get off of me.
Yeah. I was probably on top of a grown man who could probably rip me limb from limb if he wanted to, as I was like holding him and hugging him for like, I don't know, felt like an eternity. I was like, I'm not letting you go. I had this set up right for the first time in 6 months. So
that's what it's all about, man. Those are the moments that like create learning and what it's about. You can read as many articles as you want, but those side conversations while you guys are there on a Friday night drinking beer or looking back on, the faux pas of Jeremy trying to learn a technique, that's where the magic in this profession happens. And I feel like a lot of people don't get to have that experience.
Yeah.
So it's funny. I went from awkward moments with manipulations to helping teach them at times, but I knew that one was fucking coming. I was like, God damn it.
Yeah.
That and the taping in the back corner with the pants down.
Behind the door, open the door, and I'm like, okay, guys.
Yeah.
Jeremy's behind the corner taping himself.
There was a hallway that led to a bunch of other businesses, and it was like a creepy hallway with like flickering lights, and I was trying to play around with some taping sort of thing, but it was like of the the anterior thigh, so I had to get the patient to drop his pants. So Tom comes in, and I'm on one knee with the guys. He's just in his boxers as I'm taping, and it looked pretty bad. It was pretty bad. Safe to say I've not done that taping procedure since that day. So
to say the least.
Yeah.
Like for you, it's cool to watch the growth between, like, you're trying to balance providing growth as a professional with also, you knew the value in establishing that relationship with the patient. So having the fun and laughter and humor is one of the best pieces of medicine we have. So balancing that, professionalism and the laughter, like that was great and forth with all that stuff. Kicking soccer balls in like a office that was, like 1,700 square.
Yeah, this time I was breaking crap all the time, and if you didn't like support that, that kind of catapulted my own business from a social media perspective, from just a word of mouth referral sort of thing. As people would always say, they're like, well, you actually do things, doing stuff with their sports, or you're looking at those sort of things. And you did a great job teaching me, like, looking at people as they move and whatever thing. You don't need a special test to look at person, like, oh, maybe they have pain with, doing overhead press. All right, so go watch them do that. But like tying in that kind of fun sports element to keep people engaged. And if you, support that sort of thing, my business probably wouldn't have been as as good as it is. So, and I appreciate that, and all the crap that I broke back in the day. I do apologize, and now I'm getting it come back with the Justin who works for me. He's breaking things on like a monthly basis. So now I know how it feels. I'm like, he's son of a gun. Yeah, I know it was awesome way to learn and grow, and especially doing it in such a small place.
Oh yeah.
It's a tiny place.
Tom, question. So you've, when you started, it was a master's. You've seen us go to direct access. You've seen us go to the doctor route. Now, board certifications, fellowships, and residencies are a big thing. Where do you see the profession going, and where would you like it to go?
Where do I see it going? Where do I like it to go? This is where it's tough. As a profession, we're a profession that we're all physical therapists. We all work and live in the outpatient, the orthopedic world. There's a whole other side of this profession that we don't learn how to do all the same stuff.
Correct.
So we're such a small group in our little outpatient world. As a profession, we all have to kind of learn to band together. I mean, we're all dealing with the insurance stuff and reimbursement, and that's clobbering us. Reimbursement has dropped as our education and our ability to practice in a more proficient level has increased, which makes no sense. There's got to be a way that we get insurance companies and other medical professionals to kind of understand who we are and what we bring to the table for us to continue to grow. I would love to see this profession get to the point where you got somebody that comes in with a rotator cuff repair, that the doctor is at a level where we can call them, and we're not just sitting there having to get kicked to the medical assistant to leave a message for them to tell the doctor. We're doctors also. I mean, I would love to get to the point we have that respect where you're working with someone that's had a cuff repair or something, and you've got something going on. You're calling the doctor and talking to them personally, like peer to peer. I mean, it happens over and over and over again that you're getting patients coming into the clinic that's seen a doctor for 2 minutes. They come up with a diagnosis that is quasi okay, but not great, and you can't tell them that it's what you found. We're still in this world where we have to kind of tiptoe around broadcasting what we know. I mean, you can identify somebody has something completely different wrong than what the referring physician says, but you can't say it. I mean, I would love to get to the point where we're all peers in this, and we have the respect of all physicians to being at a comparable level. Because they're surgeons, they're great at surgery. We can't do surgery. I'll never say I can. But you know what? I can look at how a person's shoulder moves just as well as a surgeon can. I can diagnose somebody with a cuff pathology just as well as a surgeon can. But why can't we get that respect from that surgeon or physician for that? I mean, that's where I would love to see the profession get to from the out.
How do we, what in your mind's eye, whether it would happen or not, what do you think we need to do? Is it more people need to join the association so we have more dollars to fund advocacy? Is it, people, talking to a doctor and referring to themselves as a doctor because that's how they want to be called? Is it, let's call each other by first names because we're on that equal playing field?
Right.
What is it?
I really think the association has to go out there and broadcast that that's what they're about. And that's what's tough. Like anything that the association is putting out, it's not about that stuff. I mean, that's the elephant in the room. Reimbursement sucks. It's affecting businesses. It's forcing these corporate companies to make new therapists see more and more people to cover costs. They can't learn to be better therapists if they're forced to see more patients. It's the APTA has to speak to the therapists that are out there struggling. Their communication with these new grads that are working in these higher volume clinics, they have to say something that they are going to want to hear. And it's, advocacy has to be what we're talking about. I mean, the stuff that we're putting out so much great evidence supporting what we do, but we're just sharing amongst each other. We need to be telling everyone else what we do. It doesn't help us just telling ourselves. We need to get out there, and and that's got to come from all therapists. Everybody in every type of setting has to kind of get that there's these issues. We're just keep constantly settling instead of attacking the problem.
Yep.
I think that starts where what you said before is the students coming out need or in their affiliations, they need quality affils, because a lot of every student I have, when they go back and they talk to their other students, I've had a couple students say in a row that they feel bad for being at my facility. I think I've heard that even when I was a clinician at BSR and those sort of things. It's like, oh, we're doing everything right, but most of the classes are not. So they just get programmed to, hey, that is the norm. And then they get jobs in those said places, and only one or two of that entire class of individuals get into a good place, and they're trying to advocate. But, if you have 48 other students in shit jobs, that's the majority right there. It's just, I think there are good clinics out there, and especially with the more increase of cash-based clinics and those sort of things, it's available. It's just, maybe, students, I know I had to go out and find my own affiliations, is not settling on these, high volume places where they don't really care about the therapist. They care about the bottom line. So, and get into places where there are other people like you and Brandon and such and so forth. But, again, we need to all advocate together. So I think you brought up some great points there, Tom. Well, cheers to that. But I guess we're talking about how things have been and those sort of things. I mean, personally, how do you, I guess, stay motivated to 20 years? Man, we've talked about in a couple previous episodes. A lot of there is a high burnout ratio for something that. Yeah, I think US News continually puts us up at like top 5 professions every year. At least I think it's been since I was in our PT school of, job satisfaction, those sort of things. And it doesn't correlate with the high burnout ratio of those sort of things. So I think it is a nice thing. I guess we do, regardless of most settings, most people get, better to a degree. But eventually the grind starts to put us out. And I know even people from my own class, and I've been out for 7 years. We're a class of 20 something. I know like 3 or 4 people who are either out or they're definitely considering going out within the next couple of years. How do you stay, motivated and, stick with it for, 20 years plus?
Well, for me, I really enjoy being a clinical instructor. That's for me what creates that constant change. That's the key to burnout, is to kind of have variety. So for me, I really enjoy that. I've kind of found a nice little niche with like one school that I get, students for like 6 months. So it's like, I'm not constantly teaching students to get them up to speed. I get these students that I can kind of build up, and then I get to really spend the last half of it really teaching them the finer points, just getting to really work with them on a more in-depth level. And I think for me, it's that constant changeover of that, which helps keep me motivated. And also seeing how the profession has changed and seeing the potential. I mean, it's great to try to get them motivated to want to make better choices. So for me, that's kind of how I try to avoid burnout. It's still our days that are tough, but and then it's balancing work and life too, making sure you're doing stuff that makes you happy outside of work. It's trying to think of where I was going with that.
Beer.
I
It
agree.
happens.
Yeah, no.
Burnout comes from no variability, from just the day in, day out, and you're going in and not challenging yourself and just kind of going through the motions instead of being, actively engaged in what you're doing day to day. And I think, the therapists that just go and mindlessly go in their job, they're the ones who hate it and burn out in a couple of years. And like you said, it's not to say that every day is glorious. Like any other job, you're going to have some days that are just rougher. You wake up, you're not motivated, you don't want to get up. We all have those days as people. It's not the profession, but add that variability and find that niche that you like inside your profession. Like you said, for you, it's taking on students. It's having them for an extended period of time where you can see that growth and evolution and be a part of something else or bigger than yourself.
Yeah, and for our students out there that are listening, I want you guys to listen to what Tom and Brandon just said is, you have someone who stays motivated by being a clinical instructor. I think a lot of, just like some of us vet our students, maybe you should also vet your CIs to the degree of, you want someone who is passionate about teaching versus, oh, you're in the clinic now, you're just going to make my life easier by doing my notes. You're going to see my patients. You want someone who's going to mentor you, groom you, see how you grow, and is actually passionate about that. Too many times where it's just a CI takes advantage of their students. I personally find for a lot of his CI, having students is probably more taxing to me because I'm teaching them. I have to explain all my thoughts to them. I have to challenge them. And how I write my notes, I don't need anyone proofreading it. It's there, it's done. I send it and it goes. It's not, oh God, all right, you should add this and that. But it's part of the enjoyment of it and helping to push the profession. And I think a lot of us are, oh, I'm excited that I'm in a place. No, you should be really with someone who's going to do these sort of things. So, I know I talk to all my CIs prior to getting in, and if they're not, looking to advance themselves or push you, then maybe you should go about looking for other places. It's not too hard to set up a contract with a place. You just say, hey, I would really like to be there. Would you be interested? And usually the people who are trying to push the profession, like Tom, like Brandon, like all the other guests that we've had on the show, will go out and be like, all right, I'll sign a paper or two. It may not be for that, affiliation, maybe for two down the road, but something to definitely take consideration of for all you guys out there.
And the other thing is it's fun. It's fun to get somebody in, see them have a problem, and then you do your thing and they're better. I mean, it doesn't get any better than that. You work with a lot of athletes. To see somebody come in that, struggles with, walking or in pain, and you get to see them out back on the field. That's what it's all about. It's you involve yourself in where you're working, in the community. You end up, you work with patients, they get better, and you run into them. I remember when I was new, I was afraid to run into patients outside of the clinic. And now it's fun because it's they're always happy because it's it makes you feel good. You see somebody out doing something that they couldn't do, and you help them do that.
Yeah.
Mm-hmm.
Where our new office is, it's right next door to a gym. And it's been the best thing. Of course, with the pandemic, it stopped for a while. But I absolutely love all day long looking out the window and people I've treated walking by waving on the way into the gym.
Mm-hmm.
I'm like, how much better is that? You've got these people now. You're altering their lifestyle. They're staying active. I mean, all day long, you get the people waving, just looking in the windows. I mean, if that doesn't motivate you, I mean, that's maybe you should have thought something else to do.
Yeah,
absolutely.
Well said, man.
I think what you brought up to me with one of our mentoring sessions was, most people get 80% better, whether it's just time or just doing the basic sort of things. You have to take it that extra 10 to 20%. And I think the individuals are taking those extra 10, 20% will do those sort of things. Will wave to you, will stop in, they'll give you a gift or something like that. It's, working to get that 10, 20%. So, hearing those sort of things, obviously, and seeing you, I know that's what's happening at your place.
But that's the problem with like all these other places. If so, somebody's going to get 70% whether you do anything or not. Somebody gets their knee replaced. They were in a lot of pain beforehand. They couldn't walk. They get to 70%. They can walk okay. Their pain isn't as bad as it used to. They think it's a success. So that therapist is then validated because that person's happy. But that person doesn't know that there's a difference.
Yeah.
That's, back to being advocates, we need to weed out that type of stuff. We shouldn't be settling for that because that's really, we did nothing. We need to be able to, we should be able to toot our own horn that what we do, and we still struggle with that as a profession.
Yeah, if it takes you to get, someone with a knee replacement, it takes them 8 months or a year to get to 70%. Well, you probably didn't do, a good job. Again, it was more time or some other variables happening instead of being able to get that person 70% in like 6 weeks. So with that, like Jeremy said, that those small percentages of therapists that do go that extra mile and things like that. What would you want to see from newer grads? I guess kind of what's your future, what do you want to see from your understudies and I guess future PTs coming into this profession?
I was just say have the courage to want to stand up to, like when you're looking for your job, they just kind of take what the person's giving them. We need to be advocates for what we want. We're allowed to, stand up for yourself. If you're being told this is what your productivity is supposed to be, you're allowed to have an input in that. We need, we come out, like the new grads just come out so subservient to what the jobs they're choosing. They need to kind of advocate for themselves in the beginning, and that's the only way we're going to get away from these high volume corporate type places. If everyone that interviews for a job says this is what I want, as long as somebody will settle, then that spot is filled. Everyone has to kind of come together to build everything up, to improve it all, because it's a downward spiral. It's a business. They're going to take, a lot of employers aren't recruiting for talent. They're recruiting to see people that would see patients to make them money. We need to force that to change. It's the new grads taking the jobs and settling that continues to drop. It's just like reimbursement. If there's one company that's going to negotiate a contract and take a lower rate for a certain payer, it screws everybody.
And
so as much as that
20 years ago, that's what we were doing. That's what the profession did, just undercutting each other. And now here's where we are.
Yeah, we're paying the price for that.
Yep.
But we never ever stood up for ourselves as a profession, though. We've always just taken it. So as much as individual students have to stand up for themselves, as a profession, we have to stand up for saying, no, we're not doing this. But it's still going on.
Yeah.
And that's because the therapists will take the jobs with the high volume. The employers can negotiate these contracts to take less. It's just this vicious cycle we're stuck in.
Yeah.
I think the way that now with the higher student loan rates for the new grads, that's getting higher and higher. The salaries are getting a little lower. At some point, there's going to be a tipping point where somebody's hand is going to have to get forced. Hopefully, it's forced in our favor, where our education is worth more than what the job offers are.
Yeah.
Because all the research is starting to support it in our favor, that we are a more cost-effective option for pretty much anything musculoskeletal. I'm sorry, I don't know all the research in the non-musculoskeletal realms or neuromusculoskeletal realms. We need to, it's out there, and we need to advocate it.
But who are we telling? That's the problem.
That's the problem. I think mostly, I always kind of, marketed towards the people. Probably don't do as good of a job of going towards physicians or anyone else in, I guess, the medical realm. But that's it. It stops there. So we need to start, getting past that, getting to the other medical professionals. We need to make sure our patients are advocating beyond just themselves. Because, again, you're going to get to that tipping point. I think we're already starting to see it. Of that sort of things. Is it worth it to go get a doctorate and come out only making 60, 70K with taxes and all that sort of stuff? Is it becoming worth it?
Yeah, especially if you're looking at over 100,000 in student loans.
Mm-hmm. All right.
I mean, I feel like throw that stuff at the insurance company. Look, this is the evidence is stating that we're going to make people better, quicker. You need to pay us likewise. I think that's what the association needs to start advocating that way.
Yeah, I agree. I've always said that we as a profession play too nice in the sandbox, and I think some of the, me and Jeremy's generation of therapists and need to take more of those positions in advocacy, and because mostly advocacy is 50-year-old therapists that stop treating and now go into like that type of setting, but they have that mindset of when they practiced in the 90s, early 2000s, that does us no good.
No.
Like we need the people who've been in the trenches more recently up doing these in the advocacy roles, kind of pushing that needle forward, because we have these older-minded or older-minded therapists up in these positions not doing us justice, trying to be too nice and political with it.
Yeah, I agree.
Well, anything else? Well, I guess in terms of, we'll wrap up things with mentorship and those sort of things. Anything that you recommend, especially more towards the students or your mentees or anything like that, anything that sets them apart, anything like that, or anything that you're concerned about in regards to the next generations, as we're kind of bringing that up?
Well, the key is like when I work with you, Jeremy, it's like you're just very humble. There's no egos. That's the biggest thing when you're going through being a mentee. It's just be humble, just be open, and that's where where there's such this passion and drive to get it right away. It doesn't happen right away. It's that being patient. And it's like, I get like everybody keeps saying, well, how can you see that? I'm like, I've looked at like 1,000 knees. It's easy to see it. I've seen 1,000 knees. How many knees have you seen? And that's usually like my reference with that. It's like, like they ask, how can you see this? Looking at it a lot. Like, think about any research. The higher the N, the better the research is. If your N is, as a newer therapist getting into residency or, being a mentee, your N is still low. You have to accept that. Like for you guys, Jeremy, Brandon, you're at the point now you've seen stuff over and over and over again. You see it. It's there. But the younger therapists, they have to be patient and understand it takes time. It takes that diligence of that steady, constant looking at everything. And the key is, like I mentioned earlier, if you look at every one of your patients as a little mini case study, you're building your own evidence that way. In the beginnings of it, your N is low. You don't have that quality of evidence to really use to guide it, but you're building it. That the newer therapists have to look at it that way. It takes time. You guys didn't get where you are in one day. It took a lot of hard work, a lot of practice, and it was for both of you that steady discipline of looking at everything objectively, constantly testing, retesting. If we don't do that, how do you know what's working? You throw everything at somebody and they get better, it doesn't do anything. You have to be methodical and just be patient. Take your time. Do your due diligence.
Yeah, I remember, I had the best situation where my mentor our desks were right next to each other and we treated pretty much every day of the week together besides a couple hours. And I remember early on, it was just like, I'd be working with someone and then wasn't even an established mentorship session. You would just literally be walking by and be like, you should do this. and you would just come in and do it, and the patient was like, oh, wow, I feel a lot better. And I remember early on, I was like, fuck, shit, come on, what the fuck? Like, you're making me look bad out there. And then I was just like, wow, understanding. I'm like, oh, wow, at that point, you've been practicing for 15 years. You've been pushing yourself with education, that sort of stuff. That's the point of it. That's the whole point. You're trying to make shortcuts for me for all the things it took however 15 years for you to figure out. And if you don't have that, humble, I guess you call it humble, is just, just respect, I think, of like understanding, like that's what's the point of mentorship. I really like appreciate all that, and find those people out there who do that for you. That's all they're trying to do. It's not trying to make you look bad or anything like that. They're just trying to make shortcuts for you. And yeah, you made a lot of shortcuts, but yeah, I remember that. It's just like, I almost got scared of you walking by my clients at one point. I was like, God damn. And I started like having to think of like, I should start apologizing to my patients because they got stuck on my schedule. Because, Tom's right there and he's just like, yeah, let me do this real quick. Or, yeah, did you see this? I'm like, nope. You gotta have your humble pie. And, I always say there's always a bigger fish. I mean, at this point, 7 years, I'm going through fellowship. I still have mentors, you guys in this chat here. And I'm still learning. And, that's the big thing, is there not until the day you retire. There's always someone you can learn from, for sure.
Yeah, the second you think you know everything, you're useless at that point. 20 years, I'm still learning different things. It's great. Medicine's changing, so you have to change with it.
Well said. I think that's a good one to wrap up on. Unless, Brandon, you have any other things to stir the pot?
Great stuff. Tom, thanks for taking the time out. This was one of our longer podcasts. A lot of good stuff said. So thank you for taking the time out and being a guest on our show, man.
Yeah, thanks. It was great. Had a great time.
Yeah, this is one of my favorites already. I guess kind of wrap things up. If you guys have any questions, comments, concerns, or anything like that, seeking mentorship, like someone like Tom and Brandon, those sort of things, we're at Manips Sips on Facebook, Twitter, and Instagram. I'm at The Decent Doctor and at Trifecta Therapeutics. Brandon's at Think Like a Fellow and at Pursue PT Now. Tom, does a lot of stuff, some of the videos for BSR physical therapy. So yeah, definitely tune into that. And cheers everyone. And unless anybody else has got anything else to say.
Oh man, cheers. Tom, anything else before we wrap up?
Thanks a lot. It was awesome. A lot of fun.
Awesome. All right. Cheers, everybody.
Take care.